Okay, this is chapter 4 for Gero, and we're going to go over cultural appropriate services. Those are in which providers have an underlying knowledge of the specific cultural needs. So there's a lot of cultural competent care talked about in chapter 4. Cultural competent care is where the provider understands the basics of their culture. They try to develop cultural linguistics and healthcare organizations to understand and respond effectively to cultural and linguistic needs of patients. So if they're not English speaking, certain concerns that they might have or things that affect Western medicine, of course, would be another asset. The other thing is that we need to be, and this is a need to know, we need to assess who makes family decisions. Sometimes it's the wife, sometimes it's the husband, sometimes it's grandma. Who makes the family decisions? In some cultures, of course, they involve even secondary or external family as well. So cultural competent care, again, is professional nursing care that is culturally competent. And that means that it's culturally appropriate for that patient. We've talked a lot about that in the past, so I don't necessarily know that it needs to be reiterated that much. The cultural care triad, which is important, basically goes like this. You have the nurse, you have the caregiver, and you have the patient. This can change, of course, but essentially these three things will make up patient care. This is considered a complex relationship because they're on different spectrums of education, of culture. They could be of different ages, all types of things. So it's a complex relationship, but the ethnocultural, religion, heritage, and life trajectory is different for all three of these people, based off of education and demographics and things of this nature. And that makes the relationship complex. But know that it can include other things as well. It could be a therapist or a dad or whatever the case may be. But that's what the triad is made out of. So I'm going to try and get through chapter 5 and 6 as well during this. All right, so chapter 5. Chapter 5, all right, just to go over a couple of terms. Sarcopenia, which if you know sarcomere just makes sense, but decrease in muscle mass associated with aging. And then, I always forget this term, indenturism, but it basically sounds like dentures, which means you have no teeth. So that makes sense. And then, of course, we have dry mouth or lack of salivary glands, and then, of course, that could be agitated by anticholinergics, but the lack of sufficient salivation production, and it declines with age. Saliva. All right, so decrease in saliva as you age. Exorostoma, and that can affect swallowing, medication administration, things of that nature. So you also have, this one is a need to know right here, gastritis. All right, so basically you also have a decrease in the function of your stomach or your small and large intestine, your digestive system, and that's because of decrease in the amount of in the size and the number of glands in the mucosal membranes, again affected a lot by medication as well. But basically it means that they do not have the same nutritional absorption that somebody of younger age might have, and it decreased in villi in the intestines. And decrease in the ability to break down food. The anorexia of aging can be associated with production of cholecystokinin, which causes low hunger or satiety. Decreased thirst response, and they just don't have the ability to recognize that they're thirsty. So a lot of times they benefit from a regular scheduled drinking to prevent dehydration. And then there's also a decrease in taste perception, and that has to do with decrease in smell, and smell and taste go hand in hand. So a lot of times they're going to want spicy or seasoned foods, high seasoned food, salts and sweet need to be increased quite a bit because of the olfactory sensor decreasing. And that dis, I've never heard this term before, but essentially it's the altered taste perception, and it's a metallic or chalky taste, and it's dysfunction in the ability to taste. Healthy eating tips, and that's again a need to know. Healthy eating tips are going to be decrease the amount of sodium to prevent swelling, watching for hidden sugars, and the increase in fiber to prevent constipation, which of course is going to be important in older adults due because dehydration and then the amount of opioids and medications that they a lot of times take. Polypharmacy where they have multiple medications going on. Your daily recommended intake, of course, is going to be based on age, gender, weight, BMI, things of this nature. But your vitamin intake, vitamin D is 600 up to 70 years of age, where it will increase after that to 800. And this is based on the fact that their body's not processing. They're also not getting enough light. And then 800 after 70. Sorry, this should be that way. Okay. Calcium is 1200. That's not a need to know, but 1200 over 50, which is more than the regular allowance. If you're under 50, of course, you want only 1,000. Age-related macular degeneration is the leading cause of blindness of Americans over 50, as I was 60. Again, not a need to know. Lab values in routine nutritional assessment. You need to know albumin, the amount of protein, retinol binding, pre-albumin, transferrin, which I've not heard before, and your CBCs. You're going to need to look for hemoglobin and hematocrit, and serum folate and B12. Your medications that you want to watch out for are going to be digoxin, which increases anorexia and nausea. So as far as your nutrition goes, watch for digoxin, metformin, which is also anorexia and B12 absorption, and theophylline, which is a bronchodilator, but increases nausea, vomiting, anorexia, and decreases the absorption of B6. You also need to watch for pocketing in food, and dysphagia, of course, with older adults. The chapter 6, moving right along here. Chapter 6. Okay, chapter 6 has to do with medication administration or pharmacology. Drug intake may be affected by your race and genetics, just so we're tracking that, and we've talked about that in the past. Decrease in renal and liver function is going to be essential to older populations, so that increases the risk of toxicity. Do not rely on bun. And this is the need to know. Bun, do not rely on the blood urine nitrate because the amount of protein that they intake and muscle mass, level of hydration is all going to affect that bun level. And especially in older adults, it's not a reliable source. So look at their creatine clearance. It's far more effective for a renal test. Anemia and dietary intake is also going to affect your bun level. So bun level is not reliable anymore. You're going to use creatine clearance for your renal function. Polypharmacy, we already mentioned that, but it's the use of multiple medications where it's otherwise it's not directed. So you've got multiple medications, possible interactions going on because they have so many different medications issued by different providers. Liver kidney function is essential when you go to do medication administration for older. Again, because the liver usually have a first pass effect, which takes out some of that. And if liver function is below normal, then you aren't going to have that first pass effect in the same amount. You also won't be able to excrete it if your renal system is not working as well as it should be. Drugs that shouldn't be used with caution in older adults, and this is kind of a side note. So the liver and kidney function, so I'm getting ahead of myself. Liver and kidney function, you need to know those before you issue meds. Drugs that you need to be cautious of, new to market drugs a lot of times haven't been tested on older or younger patients. CNS effects, anything that affects the CNS. Drugs with high first pass effect, things with a narrow therapeutic range is going to be you need to really use in caution because again, renal and kidney systems are not working the way that they should be, so you have the risk of toxicity. High protein bound drugs or things that need to be bound high to protein, and drugs eliminated by the kidneys. Again, the kidneys are not working the way they should be, so kidney things that bind to protein, which again is usually low in older adults. But anticholinergic effects, and I'm sure that we've gone over it, dry mouth, inability to urinate, things of that nature. But your central nervous system is affected by agitation. It can be confusion, disorientation, poor attention, hallucination, and psychosis are possible effects of anticholinergics. Peripherally, we're looking at constipation, urinary retention, inability of sweat, decreased salivation, bronchial secretion, tachycardia, and myodiuresis, these are all things that you need to be watching for. Anyways, constipation in older adults, urinary retention. So anticholinergics are definitely, if you can find the other medication that's not an anticholinergic, by all means that usually works better. Gastric and esophageal effects, the ability to swallow, of course, is going to affect that, and especially if they have a decrease in saliva production. Gastric irritation can be caused by medication, gastric bleeding, so aspirin, things like that, NSAIDs. Antacids should not be given with calcium or a dairy product because it alters the pH and then it can't be broken down properly. Medicare Part D is used for 65 and older. It serves to help reduce the cost of medication, but remember, it doesn't eliminate the cost, so they still have some costs associated with that. And a lot of times they would use Medicare Part D with other things, supplementary things, hopefully health insurance and AARP, because other things costs really add up. The beers, the potential for inappropriate medications is really important. It's on page 142, and it's too much to list, but it goes through antiplatelets, it goes anticholinergics, cardiac, and they're all drugs that you really need to watch out for in giving to an older patient because they have the risk for toxicity or adverse effects in the older population. Haldol is another one that you need to watch out for, and some of your other ones that you need to give at night. But again, page 142 for that. And it's important to go through that Beer's list of inappropriate medication. So, and that is your summary of chapter 6 in a nutshell.